Thank you. Let me start on existing protocol. Okay. I'll be presenting to us on increasing TB COVID-19 case detection through diagnostic program integration. The emergence of the COVID-19 in 2019 led to a reversal of the many gains we made in HIV programming, TB programming, malaria programming. And this is simply because our attention was diverted to this emerging pandemic. The resources we have to be diverted also. The workforce had to be, burdened with extra load. We have to ask the people to multitask, especially our healthcare workers. And the economy was in shambles, almost all over the world. But this was not the only challenge we had. Diagnostics for COVID-19 was nowhere to be found. And so we're waiting and anticipating, what are we going to do? But eventually, some diagnostics came up. Molecular, they were very expensive. Rapid diagnostics, they were too, the sensitivity and specificity were not too okay, so we couldn't use some of them. So eventually, Cepheid, the maker of GeneXpert machine that we're using running TB, developed the Expert SARS-CoV cartridge that we can use on the same machine to diagnose, the COVID-19 infection. So we're very happy. And eventually, come May 2020, the Nigeria Center for Disease Control made available these cartridges to some of the IPs, and we're very excited. So we got these cartridges, and in our state where we program in Plateau State, Nigeria, we felt, okay, what are we going to do? Do we only screen these guys for COVID and let them go, or do we screen them bidirectionally? That is, when they come and they are presumptive for TB, we screen them not only for TB, we also give them the chance of being screened for COVID-19. And if they come to the facility for COVID-19, we also give them the chance of being screened for COVID, so that if it is either of the two, we don't allow them to go. We are able to detect whatever it is at that point in time. So what do we aim to achieve with this? We aim, to highlight the increase in TB and COVID-19 case detection among clients diagnosed with presumptive TB. We also seek to emphasize the importance of lab diagnostic program integration and optimization, especially in health emergencies. In low and middle income countries, we don't have a lot of these resources like the advanced nations. So the little resources we have in diagnostics that PEPFAR, CDC, and other partners have made available to us, we are able to optimize it, use it to get what we need. So the methodology was very simple. We look at Plateau State is one of the states in the country with a high burden of TB infection. So we selected 10 high burden, TB facilities in the state, and we implement this bidirectional screening. The screening for SARS-CoV was optional. If you agree, you will be screened. If you don't agree, you won't be screened. So those who agreed were about 3,887, and for TB, and those who agreed to be bidirectionally screened were 2,058. So we screened these. Sputum were taken for TB, oropharyngeal sample and nasopharyngeal sample were also taken for the SARS-CoV. So we bidirectionally screened all those who agreed to be bidirectionally screened, and the result was made available within 24 hours. We run them. We have 4 module GeneXpert machines at all our sites. Now, the results was interesting because we said, let's try this out from the month of May to the month of September 2021 and 2020. 2.6%, that's 102 of the 3,887 clients who were tested for TB. 2.6% were positive for TB. 8.2% were positive for SARS-CoV. And we look at the month-on-month incidence of the TB. We realize that the incidence keeps going up from 0.6 to a peak of 5.9 by September of the same year. We look at SARS-CoV also. The incidence from 0 increases to a height of 12.1 by September. And we were wondering what was going on. So we look at the data, we analyze it, and we notice that there was a spike towards the tail end of the year. And this is a table showing the results. From the month of May, the number of those who were screened, the number of cases detected, and the incidence. And then the same thing for SARS-CoV. This is a chart showing the number of cases detected for MTB and SARS-CoV. There's also a chart showing the incidence numbers from 0.6 to a peak of 5.9 for TB, and from 0 to a peak of 12.1 incidence for SARS-CoV from May to September, 5-month period. This is also showing the same thing, total number screened, number detected, and the incidence number for TB. This is the same thing for SARS-CoV. Now, this is the summary. We look at the total number that were positive for TB, 2.6, like I earlier said, 8.2 for SARS-CoV, and 0.1 were co-infected with both TB and SARS-CoV. That's 3 clients of the 3,887. Now, upon integrating the methodologies, we know that SARS-CoV-19 and TB affect the same primary organs in the same primary organ, and we know that HIV predisposes to TB infection, and TB infection predisposes to COVID infection. So these 3 are linked together. So when we integrate this methodology and we, try and we optimize this, the use of this cartridge on this GeneXpert system, there was a significant increase, like I've said, in TB cases detection from 0.6 to 5.9 and from 0 to 12.1 for SARS-CoV. We now conclude that when we optimize the capability of an existing diagnostic platform for diseases with similar pathophysiology and diagnostic technologies, this could greatly increase or enhance our case detection, especially in health emergencies. Conclusion. Today, I'm glad to say that most of the states in Nigeria, they've incorporated bidirectional screening of TB. And I read an article the other day, I think the WHO has also given advice on that, bidirectional screening. And I know most of the countries here, we have GeneXpert systems or other molecular diagnostic systems where these things can be integrated. I know there are 16 module GeneXpert machines, unlike the 4 we have at our place over there. So the more the throughput, I believe the more the cases we'll be able to detect among the population. Our introduction of higher throughput GeneXpert system, that's what I just said. Then optimizing the molecular diagnosis of SARS-CoV testing, as this remains the gold standard. Yes, I know we have a lot of RDTs that we use now for diagnosis of COVID-19, but the molecular technique remains the gold standard. And we need to synergize and liaise with medical diagnostic equipment manufacturers. Yes, we have a lot of systems on ground that we can, call on these manufacturers to help us, synergize with them so that new techniques and methodologies can be developed so that we can optimize these systems that we have. And then intensify case testing and elicitation of clusters around positive TB clients and those who are positive for SARS-CoV. We need to elicit cases from these people. And then we need to renew our emphasis at addressing the current challenge we're having, the apathy we're having to the COVID-19 vaccine. The problem is serious. Yes, people don't want to take this vaccine. And yet we know that the vaccine works. So we need to renew our emphasis on this. And renewing the emphasis includes having evidence-based researches that will prove to people that this thing actually works. We are doing some things in Nigeria right now, some studies, and the preliminary figures we are seeing is beginning to show that even healthcare workers are contributing to this problem. If healthcare workers cannot encourage the clients, they are not going to take the vaccine. And a lot of the clients want their healthcare workers to advise them to take it, and they will accept it. Acknowledgement. These are my references, and I want to especially thank the APIN-TB COVID-19 bidirectional screening implementation team and the APIN team that came here to the conference with me, the National TB and Leprosy Control Program in Nigeria, the Nigeria Center for Disease Control, KNCV, the Plateau State TB Control Program, the organizers of this conference. They have been so excellent and very detailed in all the planning. I really appreciate you, and thank you, everyone.